Mental health prescriptions are at an all-time high. American mental health is at an all-time low. Those two facts exist at the same time, and that contradiction has gone largely unexamined until now. Anxiety is rising. Depression is rising. Burnout has become so embedded in daily life that most people have stopped asking if it has to be this way. Meanwhile, the answer being offered remains the same: a diagnosis, a prescription, a follow-up in 30 days. More patients are beginning to ask what is actually happening inside that model. What does long-term SSRI use do to our emotions, hormones, and quality of life? Why are dependency and withdrawal dismissed as side effects? What should informed consent actually look like? These are not fringe questions. These are problems that a pill-first system has no incentive to solve. Tonight, 3 voices help unpack the growing disconnect between rising mental health treatment and declining emotional well-being. Dr. Josef Witt-Doerring is a psychiatrist with direct experience navigating long-term psychiatric medication, its effects, its limitations, and the patients now dealing with consequences that standard care often overlooks. Jeff Childers is an attorney and commentator who has followed the forces shaping American health policy, documenting what happens when institutional interests and patient interests stop pointing in the same direction. Dr. Simone Gold, physician, attorney, and founder of Gold Care, addresses the growing questions surrounding emotional wellness, informed consent, and modern healthcare systems. Together, they examine what led to today's mental health crisis, what long-term psychiatric medication is doing to our quality of life, and a new vision for a path forward built around clarity, resilience, and genuine wellness. The pill-first model has been failing for decades. This is where a different conversation begins. Gold Care, built for you, powered by freedom, trusted by thousands.
Good evening and welcome to Gold Care Medical Town Hall. We are so grateful you are here with us tonight. We are talking all about mental health and the issue mental health prescriptions are causing across our country. The idea of deprescribing will be a big topic tonight. Joining us is Dr. Josef. We've got Jeff Childers with us as well and Dr. Simone Gold, and we have a great conversation ready to go for you. I'll turn it over to you now, Dr. Gold.
Great. Thank you so much. I've really been looking forward to this conversation. So I have 2 people that I admire greatly. Dr. Josef, who did a grand rounds earlier with Gold Care, talking about the influence of psychiatric medications and the pros and the cons and the overuse of psychiatric medications. And Jeff Childers, I think many of you probably do know Jeff Childers. He's a very popular Substack writer, Coffee and COVID, somebody that I listen to and that I admire a great deal. And it happens that all of the 3 of us, our interests are quite aligned on this particular topic. Generally, of course, is to try to have a better medical system than we've had, but specifically the influence of too much pharmaceutical treatment as the starting point and the end point for treating patients who come to doctors with problems and issues. For those of you who are Gold Care members and those of you who are not yet Gold Care members, you would know that we take de-prescribing or getting people off prescription medications very, very seriously. I know with my experience as an emergency physician for 25 years that the list of medications that people are on has just grown longer and longer with each decade. And it's certainly not making us healthier as a nation. So we will focus tonight on the psychiatric medications. They're ubiquitous. It's one of the most commonly prescribed medications in America, the SSRIs. And I am going to start with Dr. Josef, because you are really our resident expert tonight on, I'm an expert on how addicted we are as a society to just writing pills as a solution, right? As an ER doctor, I came in, people came in, they were on long list of meds, and then half the time when I discharge them, I have to give them more meds, right? So that's kind of where I come from. Your expertise is in the psychiatric. And what have you noticed over your career in this way and about pill popping and our approach?
Yeah. Thanks, Dr. Gold. So I'm going to start with a bit of a story, and this is a story of how I ended up as a psychiatrist. So, I was always interested in personal development and philosophy, and what you need to do to have a good life. And when I went into medical school, I thought, wow, psychiatry, this is going to be a great opportunity for me to merge the love of medicine and the love of human thriving. I'm going to become a psychiatrist. But then when I entered my internship, I was really shocked because it was completely unintuitive to what I thought.
Oh no. Is Dr. Josef frozen?
Or he's having a really deep thought right now.
We're in a system where we essentially saw patients in 7-minute visits and ended up, starting a medication and then seeing them 3 times a year. And it took me a while to try and understand what was going on, how like this, intuitively I'd be thinking, well, we really need to understand the lives of our patients so we can see what's going on with their purpose and meaning and their relationships and their physical health. And we may need to coordinate with all these other experts to, therapists and such to get to the bottom of this. But we weren't doing that. And what I realized over time was essentially, it's not just the pharmaceutical industry that has kind of grabbed hold of the narrative around mental health and sort of made us look at it through a drug-centered lens. It's also a lot of economic factors, which I'd love to get Jeff's opinion on soon. And namely, it's the insurance-based healthcare system. In the 90s, the insurance-based system sort of conglomerated, and they had tremendous bargaining power, essentially, to dictate the reimbursement rates for doctors. And essentially the reimbursement rates, they just crashed. I mean, to make ends meet, most doctors needed to see 4 patients in an hour. And when you have to do that, you end up carrying patient panels of 2,000 people. Now, I would just want the audience to think, if you're looking after 2,000 people, how well do you think you really understand their lives and their relationships and purpose and meaning and their physical health? It is completely impossible to do that. And so that ended up being, I guess, the majority force that was shaping the healthcare, because when you look after that many people, you start diagnosing people based on checklists. That's, what the DSM allows us to do. 5 out of 9 symptoms, you have depression. You start treating people with protocols, which is, okay, well, you've got the depression diagnosis. This protocol says, put them on an SSRI. And that's essentially how we care for people. A lot of patients, sadly, and me and many doctors for a long time used to think, well, the way we're working, it must be because there's something behind this, that it's the most logical and correct way to help people, And one of the narratives they throw in there is that there's this chemical imbalance, right? And we all have low serotonin, and we need to be on Lexapro and Prozac to fix that. And, we're using these drugs like essentially insulin for, type 1 diabetes. They're these magic bullets that perfectly correct this underlying imbalance. And it's a complete lie. That's not true at all. The drugs, the way they work is essentially they blunt emotions. And yes, this can be really therapeutic for some people, but over time you run into a whole host of problems where the drugs wear off over time. The side effects get misdiagnosed with different mental health conditions. And so, it ends up just being a mess. What I know, I came out of my training and I was just like, wow, the whole system is a complete mess. And so, I'll stop there, but that's the lay of the land. That is what I think is going on right now. I think we have bad mental health care because of these economic forces, and we're lying to people and trying to tell them that it really is the right thing for them, but it's not. It's the right thing for the insurance companies and the drug companies and the way the system works.
Thank you so much. Jeff, I'm going to go to you, but I just want to pick up on 2 things that Dr. Josef said. One is, I'm glad you brought up the whole health insurance model. We just at Gold Care completed a white paper on health insurance and how it's really affected practice of medicine. And you're absolutely right. It's at the structure of the doctor-patient relationship changed because the forces around the doctor-patient relationship changed that kind of force the doctors down kind of a certain path. And I like that you mentioned the chemical imbalance. I remember hearing about that as a doctor, right? I wasn't in psychiatry, I was in ER. So my training was more general. But when I came out as an attending, people were talking about, oh, there's a chemical imbalance. And I said to my friend, like, what are you talking about? They're like, what? Like, we'd never, what? Like, this wasn't a thing. Like, there was no science behind it. And I think that is actually news to people who are listening to us tonight, that there is no science behind it. It was just essentially a marketing phrase. So Jeff, I had read your Substack and I reached out to you because obviously the subject of deprescribing was of interest to you. And just have at it. Like, why is this an important interest to you?
Yeah, so I'm a commercial litigation attorney, not a malpractice attorney or healthcare attorney or anything like that. And so the intersection between my legal work and the healthcare field happened during the pandemic. And Dr. Josef, you probably don't know, I filed a lot of lawsuits early about mandates, vaccine mandates, mask mandates, school boards, and so on. And it's something that you said really caught my attention. And that is when we sued Ascension Hospital Group over their vaccine mandate. And Ascension is the largest private hospital chain in the US. Just, vast multi-billion-dollar organization, all 50 states. Guess what proportion of their Medicaid, Medicare billing is of their overall revenue?
I couldn't say.
76%. 76, we learned this in Discovery, 76% of all their revenue is paid by the federal government through Medicare, Medicaid. So what became obvious to me was that the hospital, which was at that time was doing things that I didn't like. It was mandating vaccines to all of its doctors and nurses and staff, or they would be terminated. And I blamed the hospital. But what I quickly realized is that the hospital has no choice but to do what the federal government wants it to do. All the federal government would have to do is slow walk a couple months of reimbursements and it would be out of business. So that led me to a deeper dive into the whole reimbursement system, So whoever's watching may or may not know that every healthcare condition that an American has must be assigned a number, a code that allows the treating physician to be reimbursed by their insurance provider. And since Medicare, Medicaid is the big one, everybody uses their codes. So right away, you've got this funnel that forces doctors to think of everything that's happening to an individual in terms of a number and figuring out which number fits in so that the doctor can get paid. And that creates a flow chart, right? Because the number triggers then a whole bunch of other things. So when you pick a diagnosis code, then that then determines what you're allowed to do in terms of treatments that you could get reimbursed for. You can't treat the individual. You're working from this flow chart that the federal government has set up and configured. And who are those people, right? Who are the people who are deciding what the appropriate treatment for somebody who is coming in and saying that they're just not enjoying their life and they're feeling really stressed out? Okay, so suddenly the pressure is on you to pick a number for that. Which of the numbers that you have available does that person best or most closely fall into? And then once you pick that number, you're locked in now to picking the treatments that are available to be reimbursed for that condition. And to me, that seems like a horrible way to do medicine. I don't know. How do you feel about that?
Yeah, Jeff, it's really disturbing. What is closer to home for me is when I think about this in terms of inpatient psychiatric hospitalization. So when someone is in an acute crisis, you only really get coverage for about 5 to 10 days. And what are you going to do in 5 to 10 days with someone? You pretty much just put them on drugs, optimize it, and send them out the door. There's no real capacity there to get at the underlying root causes that are going on. So, I see this with emergency psychiatric care. I also used to see this, another part of this, like when it comes to insurance reimbursement. I used to work in the pharmaceutical industry as well, developing psychiatric drugs. And they had whole teams of people who would go and make the case to these different insurance companies, you should reimburse this drug, you should cover this drug, this is a great treatment, look at our data. And what I've noticed is all of the people out there who are trying to help people with non-drug approaches to mental health, different strategies, dietary changes, different psychotherapies, family support, helping people find purpose and meaning in their life. I'm sorry, they don't have $1 billion war chest to go and reach out to these insurance companies and argue for reimbursement. And so it exists on the fringe, the things that actually help people sustainably get well. And all we really end up with is coverage for drugs because they've been able to lobby for that coverage.
That's actually fascinating, gentlemen. I didn't know the conversation was going to go in this direction. I'm very passionate about this. The reason we launched and built Gold Care and worked so hard to bring it is because we're outside the insurance model. And this is the reason. You guys are literally explaining, because doctors are not free to do what is best for the patient, and they're almost not even free to think through things clearly. You mentioned early in your career, you were watching the doctors older than you that are supposed to be wiser than you doing it a certain way. So that's kind of the way you think it is. I was the same thing. Medicine is very much, it's almost like apprenticing a little bit, and you watch what people are doing. And so it takes a lot of years till the doctor's wise enough to understand that maybe what they were copying wasn't the best model. So you can't even get there if you're in the insurance model. So Gold Care, you gentlemen don't know, is completely outside the insurance model for this reason, because we want doctors and patients to be able to have real conversations so they can really get to the root cause of problems. And sometimes you need medications. We're not anti-medication. Sometimes it's indicated, but a lot of times it's not indicated, and it's been too quick. Could you just talk for 1 minute before we switch gears? Just let our audience know, you just touched on that you did a little bit of drug development. I just think that that's actually super interesting, because most of our guests have not had that sort of background.
Sure. Yeah. So when I was in residency, I was having all these intuitions that, something is wrong here. These patients are not getting better. I'm not just putting someone on Zoloft and they're sailing off into the distance and they're fine. That person's back in 6 months. The drug is worn off. They need a higher dose. And then several years later, they're on multiple different drugs. And so I'm looking at these patients and I'm thinking, how is this a sustainable way to treat people by essentially giving them drugs that blunt them, that wear off over time? There seems to be something not quite right about this. And what I kept on hearing was, don't worry, Josef, these drugs are safe and effective. They're approved by the FDA. And, at that time I was thinking, well, I'm a junior psychiatrist. I'm probably 26 years old at the time. What do I know? And so I decided that I wanted to specialize in psychiatric clinical trial research. And so I ended up finishing my residency and doing a fellowship at essentially at Janssen, which is Johnson & Johnson's pharmaceutical branch. They developed the most psychiatric drugs. And after that, I went and I worked at the FDA because I wanted to understand the research behind these drugs. Why are these drugs safe? Why are we putting 17% of Americans on antidepressants? We better have a damn good reason for doing that. And what I saw was it was frankly horrifying. The main things that I want the audience to understand right now, because everyone thinks, hey, FDA, they're keeping an eye on us, they're going to make sure things are safe. It is not true. And so the first thing is, these psychiatric medications are not studied any longer than a year in these randomized controlled trials. Why is that a really big deal? Well, it's a really big deal because the average duration of use of antidepressants is 5 years. And for most psychiatric drugs, people take them for several years, sometimes even decades. And the other thing is that all psychiatric medications cause tolerance, meaning that they can wear off over time. And so you'd also want to know, how long do these drugs even work for? And if the studies only last a year, then you can't really say that they're going to be effective long term. And the final thing that's very concerning as well is that many of these drugs, they blunt your emotions. They essentially, we don't like to say it like this, but it's true. They change your mood and personality. If you're very anxious and you take something and it helps with your anxiety, yes, that's a benefit. But it may also turn down your emotional attunement and your reactivity and what you notice around you. What impacts is that having on your relationships and your work? There are a whole bunch of questions that you'd want to know long-term about these medications. And so none of that data exists. I think people just assume it does because they're like, well, why else would we put 17% of the population on these drugs unless we had the answer to these questions? And I mean, there's one last thing that I think is really emblematic of how there's a lot of things wrong. And that last thing is that none of the drug companies put together these who put forth these psychiatric meds on the market are required to do studies showing doctors how to get people off them. They're not even required to make formulations of the drug that you can use to gradually taper people off them. I mean, there was this big scandal about Prestique, desvenlafaxine. It's an antidepressant. It's probably about 20 years old. And the manufacturers, they simply just didn't make smaller dosages of the drug that you would need to taper people off. And so even that is kind of disturbing, that there's dosages that allow you to get on the drug, but not step off the drug safely. And I mean, so Dr. Gold, I mean, that was my experience. I went through all of that. And the end of the story is essentially I became disgusted. And I said to my wife, who's also a psychiatrist, we have to do something else. And that's what we've been doing for the last 6 years. We've just been getting people off these medications and helping them find more sustainable approaches to their mental health.
Amazing. Honestly, you're an outlier, and I think a hero. I'm just going to go to Drew for a moment, and then we'll be right back.
Thanks, Dr. Gold. This pill first approach is definitely not working, and we're hearing evidence of that here from Dr. Josef and from Jeff as well. And the comments that I'm reading also agree. So thank you guys so much for this conversation tonight. I think it is very enlightening and very helpful. We have these conversations all the time right inside Gold Care. Click that link that is going across the bottom of your screen. Come and join us. We'd love to have you, and we can continue these conversations with our community. Back to you, Dr. Gold.
Jeff, I'm kind of curious, after a few weeks ago when you did your Substack article that covered the subject, were writers writing in? Were they very interested in the subject? Like, where is the public feeling about this issue?
Yeah, so it was my May 15th daily roundup. I think the title was Psychedelic. And I wrote about how Secretary Kennedy is he announced an initiative from HHS for what you would call de-prescribing. And that is what you guys have just been talking about, moving people off of these SSRIs. And he talked about all these just astonishing statistics about how many Americans are taking these drugs. I think in some measurements, up to 30% of Americans are either on them or have been on them. And the stories that people were telling about their experiences on these drugs were just horrifying. Like, I think the consensus is that trying to get off of one of these drugs after you've been on it for more than a couple of years is worse than trying to quit heroin. And nobody is telling patients that up front. It's like, don't you think you'd like to know, hey, let's try this drug, but there's a few downsides I need to let you know about first. And that was, I think, where the response from readers was strongest, is that the system is broken on so many layers, right? So Dr. Josef, you were talking about how the FDA is not doing its gatekeeping job properly. And so what does that mean to like everyday consumers and patients? Well, we don't really follow the FDA's advisory. So the FDA is an agency that's supposed to be speaking to practitioners, right? That's where you guys are getting informed about the data that you need to provide your patients with informed consent. Then in the office, you've got a patient in front of you. The patient is, depressed. Maybe they're, having some profound mental health issues, and you're suggesting this treatment to help them, and the patient is expecting you to provide informed consent. And as a lawyer, I'm very careful about how I define informed consent, and that means that the doctor's not just supposed to tell you about what the drug does, but about any risks of taking the drug, any alternatives that might be available to that particular treatment, and what the real efficacy is. So not just the relative risk reduction, but actual risk reduction and things like that. Like, so, out of 100 patients, how many actually see improvement? None of that happens in modern medical care. There, as far as I can tell, there's zero informed consent happening in doctors' offices.
Yeah.
The doctors don't have time to do it.
I can't speak for Dr. Josef because his practice in psychiatry may have allowed more time. I can tell you in the ER and also most primary care, that's true. That's true, Jeff, that we really are told and we then drink the Kool-Aid, oh, it's safe, and we just prescribe it. And it's embarrassing a little bit when I look back on my career and things I didn't ask. I questioned more than most, you can imagine, but I don't think I questioned enough. Dr. Josef, I'm kind of interested because we do want to be balanced as much as possible on these issues. Should anybody be on SSRIs? I guess that's kind of my general question. Like, is the little bit I know is that they're not even that effective, like even putting risks aside and all that. Yeah. So what is the best scientific answer to that question?
The short answer to that question is there is a use case scenario, and I will go into it, but I do want to comment on the informed consent issue. There is no standard anywhere for what informed consent is in medicine. And so, I always see it in the notes when I do expert review, risks and benefits discussed, with the patient, it turns up in the chart. But the reality is, these people are going in and seeing the family medicine doctor. They're spending their 7 minutes of FaceTime, half of the time talking about their cardiovascular disease and the last couple of minutes talking about their depression. And then the patient says, hey, is there anything that I should be aware of? And they'll say, yeah, some people get a bit of jitteriness, maybe a little bit of, nausea, but these are some of the safest medications out there. Okay, great. The patient then goes to the pharmacy. As they pick it up at CVS, the pharmacy tech slides a little electronic keyboard towards them. Most people don't even look at it, but what it says is, have you been given a chance to discuss this medication with the pharmacist? And people just go, yes. And then they get the drug. It comes in a baggie, and in there is a small print medication guide, which people they essentially just throw it away because they say to themselves, if there was something really significant here, my doctor or my pharmacist would have talked to me about that, it. And so they take it. So there's structurally within, the family medicine offices, there simply isn't enough time to do it. And so we need to get more creative with how we do informed consent. Something that I was talking about to the FDA last year, and I try and bring it up to whoever will listen to me, is that we need to put QR codes, on the bottle caps of these medications that say, watch me. We have the technology now where someone could do exactly what Jeff was saying. They could be a 15-minute, educational video on there that talked about the most important risks of the drugs, the alternatives, the gaps in the evidence, what we know, what we don't know. And we could do that at scale, and we could really save a lot of people because the current informed consent process just makes no sense. And so anyway, I'm going to keep on banging that drum until we make that progress. But I'm going to move on now because I know you asked about, is there a use case for SSRIs? And there certainly is, and there is for all psychiatric drugs. We don't want to throw the baby out with the bathwater. But it comes down to understanding, what do these drugs do? And so with SSRIs, they have a numbing effect. I know there's a lot of data out there that says, hey, they're just placebo, they don't do anything. I have taken Zoloft. My wife has taken Zoloft. I've prescribed it to 1,000 people. I know inside and out, what these drugs feel like. Believe me, they turn down your emotional range. And so that's why you can get someone who's really suicidal or very anxious, and you give them this drug and they say, oh, I'm more functional. And so I think especially short term, that can be helpful. Now, the problem with these drugs is always in long-term use. And we start to worry about the fact that the drug just wears off over time. You just develop tolerance because your body pushes against it. It doesn't like being in a perturbed state. And so what that means long-term is you need to take higher and higher doses and eventually additional drugs if you want to maintain that same therapeutic numbing effect. And so as a sustainable long-term option, it's really, you really want to find another way. Now, in terms of who should take these drugs, I mean, there are horrific side effects that people have never even heard of. Jeff was mentioning.
Presumably, Dr. Josef will come back shortly, but Jeff was mentioning how hard it is to extricate
withdrawal reactions when they try and come off these meds. It can be absolutely horrific, like the hardest thing they've ever done. And there's also a small group of patients who develop a condition called PSSD, which is post-SSRI sexual dysfunction, when people get on these drugs, and usually when you're on these drugs, 50 to 70% of people will have lowered libido and sexual dysfunction, but they assume it's going to go away afterwards. Now, there's a small group where it doesn't go away. They essentially find themselves feeling chemically castrated. And so there's also these horrific side effects, which albeit they're quite uncommon, but they're concerning enough that most people, I think if they actually knew them and they had proper informed consent, they would say, I am not going to take this drug unless I've tried everything else. And if I do take this drug, I'm going to make sure that I take it short term with a concurrent plan for getting off these drugs, so I don't have to be on them that long and there's something available to replace them. That doesn't happen with most people. They just get put on it and then they get parked on the drug and then they just end up taking it like every they see their doctor every 3 months for a check-in. And that's with no plan to come off.
And let me just tack on to that. The use case issue is very interesting. And I agree that, from my position as a lawyer, I see, I get, and as an author, I get feedback from, I write an article like this and I get feedback literally from thousands of people instantaneously. And it's clear that some people have experienced life-changing positive outcomes from any of the medications that we could talk about tonight. And so that's, impressive. And we don't want to throw the baby out with the bathwater, and we want these things to be available to help people who find themselves in crisis. And so, folks who have, like I said, these serious issues, manic depression, schizophrenia, depression at levels of suicidality, things like that. There is a strong argument that the risks of not treating them are greater than the risks of taking this drug, whether it be, the withdrawal symptoms or, the potential risks of sexual dysfunction, even permanent, and so on. Right? There's a clear risk reward structure. And if the patient had informed consent, they could make that calculation. But I really wonder about the, 30% of Americans. 30% of Americans are not in the category of manic depression, schizophrenia, or suicidality levels of depression. So who's making the risk reward calculation for them? If they were presented with, hey, you've got a little bit of anxiety, you've got a little bit of depression, right? You're sad. Your spouse passed away. And let's try you with this SSRI because, it's supposed to help blunt those emotions. And then there's no discussion of these potential severe side effects, however uncommon they are, where the risk of encountering that side effect is, for that person, given the relatively otherwise treatable using alternative, a 30-minute walk every day, right? An exercise program, something like that. The risk reward just doesn't calculate. The math doesn't math.
I have a question based on what you both are saying for Dr. Josef. Oh, goodness gracious. I hope he comes back. He probably lost his internet connection. But given that he had his training and what attracted him to becoming a doctor and a psychiatrist was a deep philosophical. So this is a kind of question for you, Dr. Josef, because you kind of went to medical school with kind of a interest in humanity, in the human condition. So because Jeff, you just said, you're sad, your spouse died. So there's no question that there's situational reasons why people present to doctors, and then doctors are wired to want to do something, and we're trained to do something is meds, essentially. But as a humanist and a philosopher, can you speak, Dr. Josef, to the necessity of humans, again, excluding severe psychiatric disease, of going through these situations and coming out the other side as an intact person, as opposed to blunting the emotions of it? Because that, I feel as though in America, we're clearly just trying to blunt our way through difficult things. And it seems to me that that is not a good solution for humanity. I'm curious.
No, yeah. I mean, I think it doesn't make sense on multiple levels. I mean, I think about it as a parent. Like if I had a child, and every time I have two kids, every time they experienced a difficulty, I was just take this medication and, let's just erase the feelings rather than helping them through, what they're struggling through. That's kind of just an important part of general emotional development. And so I think we have completely normalized taking medications to deal with problems instead of getting to the underlying cause. Sometimes it's obvious, sometimes it's like, okay, you're in the wrong relationship or you're in the wrong job. And obviously the idea about just drugging yourself to tolerate something when your body and your mind is telling you, hey, this is bad for you, that's a disaster. You're essentially staying in a bad situation that should stop. The other issue that's happening in the US is, for a lot of the people who say, I'm just depressed and anxious and it's just coming out of nowhere, they're having physical health problems. I mean, the majority of our country is overweight. They are inflamed. They are in a state of chronic stress and sympathetic overdrive from their poor health. They have terrible sleep. And we're not doing them any favors when we just say, just take the statin, take the SSRI. Don't worry about the fact that your body is screaming for, for help. And so we mask the problems. These health things fester in the background, and they end up with all this, chronic disease and essentially not getting better. So, yeah. I mean, we're completely neglecting, helping people grow through these struggles. But I mean, because at the end of the day, what are mental health symptoms? I mean, this is the smoke alarm for our mind. Like when we're anxious, when we're depressed, when we're not sleeping, these aren't like, you develop sleeping disorder or depression disorder or anxiety disorder. It signals that there's something wrong in your life and you need to listen to them, and then you need to make changes. I mean, it's a feedback mechanism.
And by the way, it's also so severely overdiagnosed, right? And that goes back to what you said at the beginning of this hour, which is you have to fit into, Jeff, as you said, you have to fit into a number. And as Dr. Josef said, you have to fit into like the 4 people per hour. The doctor with 2,000 patients has to triage the patient into something. So if a person is just beginning to talk to the doctor and say about the anxiety, the stress that they're feeling, whatever's going on, they have to fit them into, and next thing you know, on their chart, it says depressive disorder, right? And maybe the person just wanted to sit and talk and vent.
And I want to add something to this, Dr. Gold, as well.
Goodness gracious.
He'll get there. He'll spring back and pick up right where he left off.
It'll come right back. Hopefully comes back in a moment. When we come back, I'm going to go to Drew for a moment, but when we come back, I'm excited to talk about 2 things, a little bit off SSRI, but all about mental health. And one of them is marijuana, because there's a lot of talk about marijuana, and I really want to get Dr. Josef's insight on that. And then you had sort of mentioned it, Jeff, and I don't know if you have anything to say. It's particularly on the subject of psychedelics. So we do want to talk about those 2 things. Back to Drew.
Thanks, Dr. Gold. Yes, what a great conversation. And there is a ton of great comments and commentary in the comments section tonight. I do want to remind everyone that this is just an open forum. This is all for educational purposes. We aren't giving medical advice here. We're just having a conversation on our topic of deprescribing and psychiatric meds tonight. So if you do want more help, more questions to be asked, you want to meet with doctors or just a like-minded community, we do that inside Gold Care. This replay of this town hall, plus all of our other classes and educational information are available in Gold Care. But we're having a great conversation tonight, and we are so appreciative. Let's get back to it, Dr. Gold.
We've always approached at Gold Care that the physical health is also, there's mental health and there's spiritual health, and nothing's forced on a patient at Gold Care. But we have, for example, we have a faith class every Wednesday. It's one of our most popular classes because we just know that they go hand in hand. People's mental health, there's psychiatric, their well-being and all that, and their physical health. And it's very severed in the what we call the medical industrial complex. But before, I don't know if you were able to hear us, Dr. Joseph, I wanted to ask your opinion on two things. One is marijuana, either marijuana generally or medical marijuana. But I have my own very strong opinions on this. And then also maybe the both of you, if you have something on that, and psychedelics, just because Jeff had actually mentioned it. So we'll just start with you, Dr. Joseph, on those two. Definitely marijuana is an issue people are very, very curious about.
Yeah, the marijuana nowadays is not, it's not the same drug that people are used to. It's causing an epidemic of essentially bipolar and schizophrenia misdiagnoses. And every time a doctor complains about, we should be more careful about marijuana, people just go, this is just some reefer madness doctor who, has some ulterior motive and they just don't like drugs. But what I want people to know is that back in the 70s, most THC was around 3% concentration. Going up to the 2010s, it was really sitting around 5 to 10%. And then it hockey sticks up aggressively from 2010 onwards. And then we start getting THC concentrations around 15%. And now if you go into a dispensary, it's very easy to get 20%, 25%, 30%, 35%. And if you're smoking concentrates like wax, dab, and shatter, that can go up to 90%, and also vape pens. Now, why is this a big deal? Well, this is a big deal because there was a study done about 10 years ago that put together two cohorts of patients. One group was smoking this 5% stuff, and the other group was smoking the 15% stuff on a daily basis. And then they measured the rate of psychotic conversion in those two groups. The group smoking the 5% stuff, this is the stuff from the 70s and prior to the 2010s, their background rate of psychotic conversion was 1%. Which is in general just the normal background rate in the community. And so there wasn't really an increase when you were smoking the low potency stuff. But when they looked at the group smoking 15%, it went to 5%. It essentially 5x'd. And so why is, and that's 15%. Like I said, most of the stuff people are smoking in the US today is 20 to 35% from the dispensaries. Now, what does this look out like in clinical practice? Because this is what I see, and this is why I started talking about this. You get some kid, he goes away to college, super bright, really functional, joins a frat, starts smoking cannabis products there, and then has a psychotic episode. Now, most people have a misconception about psychotic episodes from drugs. They think, hey, if I have this, psychotic event, it should just go away when the drug clears my body. It's strictly related to the drug being in there. That is not true. These drugs cause brain damage in some people. When you are having this confused, psychotic, paranoid state, that is a sign that you're having a severe adverse reaction to the drug, and it can be damaging and harmful. Because what I've noticed in my patients who go through this is sometimes it can take them many months, even sometimes up to a year or two, to fully recover from the mood instability and the paranoia. Now, what happens to these kids is that doctors, they look at this and they think the same thing. Oh, well, it's just some cannabis. It's out of his system. He should be better. But when the parents say, hey, he's still having delusions and paranoia and mood instability, they say, well, you have bipolar disorder now. And then they put them on an antipsychotic. This completely changes the trajectory of someone's life. And so I think, I'm extremely worried about, all of the pro-cannabis messaging now, the fact that there's these waves of legalization, the fact that, the Trump administration.
We're gonna get Dr. Joseph a better internet connection next time. I was going to share, Jeff, right before you speak, that I had some experience with this as a mom. Actually, I had two teenage sons at the time, and I was fairly liberal about marijuana use because I just knew the battle was essentially lost where we were in Los Angeles, and I felt it was safer in my own home. So there was one day that the kids were home, and there was like 6 or 7 boys sitting around, and they were using marijuana. And then all of a sudden, one of the boys had a full-on psychotic break. And I was home, and I'd heard about this being a possibility, but I had never experienced this. So the kid runs out of the house and starts, he was absolutely full-on psychotic. He was paranoid, he was delusional, and he's running down the street, and he's running into traffic, and he's running, and it's a miracle that he didn't get hit and killed. And I start running after him, which is insane because I can't catch a teenage boy, right? So then my other son like jumps in the car and drive, and we're like chasing him, and he's running in the middle of the street. I mean, it was unbelievable. Thank God he wasn't hit by a car, and we kind of steered him. We called his brother came in, and they met him. And I had such a long talking with him and his family. I said, because I didn't understand it the way you did, Dr. Joseph, but I knew for sure, common sense told me this kid was at high risk of having another psychotic break and maybe schizophrenia, and I gave him the riot act about never touching the stuff again. But what was so dramatic was that there's about 6 kids there, and they're all using it, but only one had the break, right? Mm-hmm. So I want to share with everybody listening, you don't know if you're going to be the one. You don't know if your child is going to be the one. It's absolutely real. It is not some hyperbole that some, like you said, reefer, whatever saying. It's absolutely real. I just wanted to validate that while you froze for a moment.
Yeah, thank you.
Jeff, I don't know, is this something that people talk about? Like, that they mention, is this an issue that's on your radar screen?
So, I've covered this from sort of the social level. If you go into the states and locales where they have decriminalized marijuana use broadly, such as Colorado, where these states where recreational use is permitted, for example. Although increasingly it's really hard to separate so-called medical use from recreational use because it's so permissive. But if you go to those areas, then what you find are just more problems. Serious, profound social problems. If you ask most Coloradans now about the decriminalization that they undertook 10, 15 years ago, they all want to go back. And they want to, they wish they hadn't voted that way. It's just funny how we've gone from the reefer madness style, anti-marijuana posture that I think has caused the activists to be so defensive, because they remember, what it was like when everybody thought that they were hippie potheads and nobody listened to them. And, now they're finally getting some attention and big money, and it's big business, which is another problem. But the other side of the conversation is getting lost, and that is a conversation that I think really needs to be had. The psychosis, but also just the cost of society in general.
And the dosage. People don't ever. And I looked into it, Dr. Joseph, and of course, what you're saying is exactly accurate. People have no idea that the dosage has changed so dramatically. I mean, you're talking about triple strength, or sometimes 5 times the strength that it used to be. So if this is something, there's thousands of people that are watching this. So if this is something you're struggling with in your home, if you're the parent or you're the kid or you're the uncle, just know that the marijuana that's out there that the kids are getting hold of is not the same as you remember when you were 18 years old. It's much, much, much stronger. And the risk of a psychotic break is real. And it causes, as you heard from Dr. Joseph, potentially long-term. I mean, it was very dramatic, the one instance I saw of this. It was really incredible. Just to turn to one other issue that I know that you're interested in also, Dr. Joseph, it's psychedelics. Like what say you about how that's going to influence the future of psychiatry?
Yeah, I like psychedelics, and this is coming from someone who really doesn't like a lot of drugs, and so I want to share why I like it. I like it because of how it's packaged. Now, so all of the clinical research for MDMA, psilocybin, it all comes packaged with a therapy, and so you have to understand what the doctors are trying to do with these drugs. They are using these drugs to help people gain a new perspective on problems in their life. And so it's not just, you walk into a room and trip out for, a couple of hours. You go and you meet with a therapist. Usually these are people with addiction problems or severe trauma that they've gone through. And you could imagine, let's say it's someone with severe trauma, childhood sexual abuse. And they have now learned that people are not safe because maybe something happened inside their family. That is just a defensive position that has been stuck in their mind. And this now plays out in all of their relationships. It also plays out in perhaps some low self-esteem. If I was a good person, I wouldn't have been abused. And when you have that low self-esteem, maybe it impacts your career. That happens to a lot of people. But when you can change your mood drastically with a psychedelic and get a new perspective on things, that can be really helpful. And so usually it's someone like that. They meet with a therapist, they set an intention for a problem that they want to work on. They then have a supervised trip with a therapist who helps them gain new perspectives on problems that they haven't been able to see before. And then you meet several times with a therapist afterwards to integrate those new perspectives in your life. And so think about it as like therapy on steroids. Is this going to be a panacea for all anxiety and depression? No. This is not going to do anything for the person who's overweight and is, having sleep problems or dietary issues, or, that's really not where this fits in. But as a targeted intervention for those kinds of problems, I think it has tremendous potential. And me personally, if we can move away from the model where like someone comes in and they complain of symptoms and we just put them on a daily drug to numb them out, to something more empowering and driven by the patient, where they have to take responsibility for, yes, this is my new perspective. Yes, I'm going to integrate this in my life. That's a much more like empowering and in control way to help. So I think it's going to be great. I think there's probably going to be some bad actors out there that kind of ruin it by stripping away all the therapy and the good stuff and just sort of scaling it by, giving people these psychedelics. There's always going to be people like that. But at its heart, I think it is a good move.
So it's very interesting what you're saying, but my question, where I want to push you is, if they're putting 30% of the country on SSRIs, obviously 30% of the people do not need to be on psychiatric medications. I would get worried about using something potentially potent like this, it being overused. So what do you like? How are we cautious about who gets to use it, knowing as you do how aggressive the pharmaceutical companies will be?
I feel like I'm cynical because I think that it's going to be inevitable. Once this comes on the market, Dr. Gold, people are going to be bombarded with Facebook ads saying, hey, feeling burnt out, feeling overwhelmed. Have you thought about taking some magic mushrooms? FDA approved. That will be everywhere. There will be such a big incentive to market and push this as a panacea for everything. They will turn up at a retreat where there's underskilled people, and they will just kind of sell them on the drug experience. They will expose people to the risks of mania, which is a risk of doing psychedelics. And so I think, sadly, a lot of these problems are inevitable because that just seems to be how the economics of healthcare work. And so I think you're really right to be skeptical and worried about this.
So that's why we do these town halls. That is the truth, because we don't want to throw the baby out with the bathwater. So you, as a scientist and as a psychiatrist, have looked at it. You see promise there, especially for people who have had a major trauma. And I can understand that. I would concur with that. I was concerned with the policy implications, but that doesn't mean for an individual patient, it's not a really excellent alternative. And that's why we do these. That's literally why we do these town halls, so we can hear all that. So Jeff, this might be the first time you've ever heard this. I don't know.
So, all right, let me broaden it out and put some optimism back into the formula here. And Dr. Gold, this is going to be a plug for you. And I just want everybody watching to know I'm non-compensated.
Yeah, it's true. You guys are truth tellers. You're here because you're truth tellers.
Yeah. So, Dr. Gold, what you will remember is that during the pandemic, when, in some of the worst times, when the institutional medicine, the hospitals and doctors who were orthodox doctors were only prescribing a very limited range of treatments for severe COVID. So if you had a relative with severe COVID, then they got remdesivir and the ventilator, and that was their only choice. And if you didn't want them on remdesivir or the ventilator, you had no recourse to institutional medicine. And so what a lot of people began to do, and you were one of them, is talk about parallel systems, is creating separate healthcare systems for people to use that were more like traditional medicine, more like the scenarios that you guys were describing earlier, where your doctor knows you and you have a long-term relationship with your provider. And they don't have 2,000 patients. They only have 400 patients or families. And you take insurance completely out of the loop, where it's a direct pay type of system. And my family here in Gainesville, we have a local concierge practice that we pay for. Basically, it's like a general practitioner for a whole family. We can text them anytime we want. We can get a phone call answered. If we need a prescription, we can do it by text. They leave it in a Dropbox. We can pick it up in the middle of the night. If that's the first time, it's on the outside of the building. You punch in a code, it opens up, and there's your prescription. I mean, it's better than traditional medicine in 1,000 ways, but they know us and they're interested in us, right? So when we go in, for any reason, they ask how the kids are by name. I think that's how it used to be. And so I think that what's happening is, quietly, in the wake of that pandemic experience that we all suffered through, there is a parallel track that is developing, a medical industry that's outside the medical industry. And that, to me, is the most promising development of all. So, for example, if I have a relationship with a healthcare provider who I trust, then when I see the ad for magic mushrooms or a weekend retreat at the community college, to trip out and have this guided experience, I can text my healthcare provider and say, do you think this is a good idea? And they'll give me something that's helpful. No, stay away from that.
And Jeff, what I want to jump in on and share about is that, think about the incentives, right? With direct primary care, you just pay a flat monthly fee to see the doctor. That doctor is incentivized to keep you well, because it means you're less of a hassle for them. If they're doing all the things they need to do, if they're making sure you don't make mistakes, their life is easier. But in the insurance model, where it's just fee for service, they don't care. They want to. Every time you come in, they get to bill the insurance, and so even like the incentives of that system are just better for the patient.
Yeah. Exactly.
Yeah. So the bottom line, we need more Gold Care.
Right.
How's that?
Right. Yeah. So we really, I'll take even what you're saying one step further. We actually want to not make everything so oriented around the physician experience, the medicalization. We think a lot of things have become medicalized, maybe shouldn't become medicalized. Obviously, we have amazing doctors at Gold Care. Obviously, it's the core of what we do. But we also know that a lot of people's issues or problems or questions can be solved with education, and they don't necessarily need a one-on-one with a doctor. They need to listen to a talk like tonight. They need to, we do talks on statins. One of the things we help people get off of a lot is statins, because statins are really not something people should be on. Statins and SSRIs probably are the two most popular prescription medications. So we want to help you help yourself, be empowered, and then to have that expert, by your side when you need that expert answer. I want to thank you. For me, this was a really big pleasure to talk with both of you. I found it very, very interesting. And I don't know, any last words from maybe we'll flip the order now, maybe from Jeff first and then Dr. Josef.
Yeah, so just to put a cap on that, I think that I would also throw AI in there as another optimistic development. We don't have time to talk about it tonight, but having that in your pocket, you can sort of get your own informed consent to double check if you're in the institutional system. So that'll be my last thought to throw in there.
Yeah, it is too much to talk about tonight, but I will tell you that you can use AI intelligently. You don't have to be afraid of AI, but you have to be able to use it intelligently. And we are not teaching people how to use AI intelligently. So we'll talk about that again one day, Jeff.
Another conversation, yeah.
Dr. Josef.
Yeah, my final last words are your emotions mean something. If you're anxious, if you're depressed, all of that is coming from somewhere. If you can't sleep, please lean into that. Do not allow someone to just say, hey, you know, it's just a brain disease and we have a pill. That's not how the body is designed. So how you feel really matters.
I love that. And it's also what I wanted to say at the end, which is I mentioned before, which is this spirituality. You know, humans are made up of bodies and souls. We're made up of both, or whatever you want to call it, if you don't believe in soul, whatever you want to call consciousness. We're made up of both. You need them both to be working. If they're not working, you will likely have physical symptoms. So we want to encourage you to look at the body as a whole. If you can't sleep, you're anxious and all that, like Dr. Josef said, there's a reason. Don't just ignore it. Don't just numb out from it. We're here to help you at Gold Care. We're here to give you doctors and education that's genuinely helpful for you. I want to thank you both so much for your expertise and your time. Thank you.
Thank you, guys. Thank you for attending tonight. Dr. Josef and Jeff, thank you so much. Great conversation. Really amazing to hear all about what is going on in this nation, what people are dealing with, and what Gold Care is doing about it as well. So we ask you to join us, goldcare.com/Dr. Gold. We look forward to seeing you, learning with you, and helping you. Next month, we are talking all about cancer. It'll be a great town hall. We will be sending out information on that very soon. Again, thank you for joining us tonight at the Gold Care Medical Town Hall. Have a good evening and God bless.
Do you feel like the healthcare system is failing you? That's because it is, working exactly as intended to prioritize profits, bureaucracy, and big pharma, while leaving you and your family vulnerable when you need care the most. We understand your frustration. You've been asked to trust a system that feels rushed, impersonal, and biased. You deserve better. That's why we created Gold Care. Here, your values matter, your choices matter, and most importantly, you matter. Gold Care is more than a solution. It's a revolution. Trusted by over 10,000 members nationwide, we've built a system that puts your wellness first. With ethical, independent doctors who work for you, not the system, you'll have access to care that's transparent, trustworthy, and aligned with your values. We understand that stepping away from the familiar can feel daunting, but staying in a system that doesn't truly serve you is even harder. That's why Gold Care offers a healthcare alternative designed to work for you. Whether you're ready to step away from the system entirely or prefer to keep your insurance while seeking the transparent care, ethical doctors, and education you deserve, it's time to stop trusting a system that's failed you. Take control of your health with Gold Care. Join today for $17 a month and become part of a healthcare revolution. Gold Care, built for you, powered by freedom, trusted by thousands.